This is the case of immature cataract. As you can see, the cortical cataract is the predominating one. Saline. Now I'm doing the incision and side board. As I do every time, I go with both at the same time. Now there was some pressure from the speculum, so that I released the speculum a little bit. Now I'm injecting the OVDs, the dispersive OVD, into the anterior chamber. And as the anterior chamber is shallow, so I'm going to inject some sodium hyaluronate with the dispersive OVD, just to keep the anterior chamber formed properly and to deepen the anterior chamber a little bit, as this anterior chamber is sub 2 millimeter depth. Now doing the central puncture in the anterior capsule, and now doing my hydrodissection for the desired size. When I do a hydrodissection, I like to sweep over the capsule. I don't do ribbing movements, I only do shearing movements to be able to draw my rhexis without any escape of the rhexis. And now the rhexis is properly done. I didn't go in this case through the sideboard with a support cannula because the anterior chamber is a little bit shallow, and this is the challenge in this case. And now with the injection, the whole of the lens is having the tendency to come into the anterior chamber. So as the anterior chamber is shallow, I prefer to go with a dispersive OVD again into the anterior chamber before going with my phaco probe, as I did here. This will be much better for engagement of the probe into the anterior chamber. Procedure 3. Now I'm adjusting the head of my patient again. And this is the step of phacoemulsification. Usually I don't change my technique in different grades of cataract. Here I went into the anterior chamber. This is my chopper going under the anterior capsule. I know that this case is a shallow anterior chamber, so that it's very essential to have plenty of shops of the nucleus as possible as I can. Then there is some fluctuation as well in the anterior chamber because of the saline, because I think some positive pressure. Here I'm starting my shop. Yes, it succeeded to do the first shop. Then I'm going to have I'm showing now the eye, showing now the cataract, sorry. But because the anterior chamber is not stable, so that started to change a little bit of the technique is to go into the bag with the tuber every time, and I don't like that much. But here sometimes I have no options to come outside the bag with the tuber, then to come again into the tuber, into the bag. Yes, this is somehow a challenging case because of the turbulence and instability of the anterior chamber because of the positive pressure coming from behind. But at the same time, I don't like to elevate the bottle more because elevation of the bottle in such cases may do a posterior direction of the BSS, so that I keep my fluidics the same and I just release the speculum a little bit and decreasing the size of the nuclear materials to be able to emulsify inside the bag. Here in this case, the bottle is 60 centimeter and I don't like to have the bottle elevated more than that in all of my cases for the fear of aqueous misdirection and for overstretching the capsule, and it will make the capsule liable for rupture with any touch if it is very stretched. So it's better to keep the lower bottle height and at the same time to try to manage the case in a slow motion phacoemulsification and guarding the posterior capsule with the phacotuber. Almost we are finishing the last part of the epinucleus. After that, we will be there for the IOL. Here, my main issue is to be away from the endothelium and at the same time to stay safe for the posterior capsule. Now we'll shift to the IA in the normal way with the IA aspiration cannula. I'm using a coaxial IA so that we'll go with the IA through the main incision, not a bimanual. I like the coaxial IA because it gives me the same flow inside the anterior chamber like the phaco handpiece. Now this is the cortex parameters. I'm using linear vacuum with fixed flow rate, aspirating the cortex in one bulk, then taking the cortex from inside the eye by the IA handpiece. As I mentioned that if the anterior chamber is irregular depth, is shallow and at the same time there is some fluctuations during work, I don't like to elevate the bottle not to increase the intraocular pressure. And I just remember that this patient has an optic atrophy in the other eye, and most probably this was the situation with the previous surgeon, that due to fluctuation of the anterior chamber he elevated the bottle to the maximum, and this may affect the optic nerve, so that whenever I find some fluctuation of the anterior chamber, I don't like to proceed with elevation of the bottle or increasing the intraocular pressure in my case. By any means, this elevation of intraocular pressure may, may induce Webb-About syndrome, which is ischemia of the posterior segment due to the too much pressure inside the anterior chamber. Here, this is enough. And now I'm going to implant the IOL. Now this is a cohesive OVD into the bag, forming the bag and the anterior chamber as a preparation for implantation of the IOL. Now I'm going to inject a preloaded IOL so that I'm hydrating the IOL first inside the cartridge. Now injecting a cohesive OBD into the cartridge, then proceeding the injector a little bit anterior to this position, making sure that it pushed the IOL haptic to the desired position, then closure of the cartridge, then pushing the cartridge, checking the IOL is moving. Yes, the IOL is moving properly. Then proceeding with the IOL into the distal part of the cartridge to enter the eye, keeping pressure, keeping pressure, keeping pressure, don't release, and you can release and repress, release and repress, release and repress. Yes, now the IOL is inside the eye. Now reposition the IOL into the bag. Yes, and give it time to unfold inside the bag. Now the IOL is positioned inside the bag and this is perfectly unfolded. Then doing irrigation aspiration or visco removal from the anterior chamber and behind the IOL. I like usually to wash behind the IOL for fast improvement of the vision and give a short time for the IOL to take its final effective lens position. I don't like usually to remove the OBDs from behind the cornea, and it doesn't matter if it is including some cortical material like here in this case, but no need to remove it as it will wash out by itself in the coming day. Now hydration of the main wound and hydration of the side port. Next time I think we'll proceed with another technique. This will be coming Monday. I'll do divide and conquer and some modification of the divide and conquer technique. This will be next week, so please wait for the live transmission next week, same time.